I'm Professor Jacqueline Parks from the University of Northampton, and I founded and co-lead our Dementia Research and Innovation Centre there. I'm your chair for this next session, and it is my pleasure to be able to present our speakers in a moment. As I said, I have a couple of announcements first. I also have a lot of bits and pieces. I feel like I'm juggling slightly. So, for those of you that are registered to the welcome reception at the City Hall, please can you make a very rapid exit to those buses? Can you move swiftly? In other words, can you leave as soon as possible for your transfer buses? Those of you that are registered for the reception to go to City Hall. Okay. So this session is the young-onset dementia session, and we are hybrid. So I want to welcome my colleagues who are online, and we will be obviously monitoring questions. It's a real pleasure to be able to open this session and to welcome Louise Nygard from Sweden. She is an, oh, I've just lost it. Professor Emerita of Occupational Therapy at the Karolinska Institute in Stockholm, Sweden, where she's been doing research for 30 years. And this afternoon, she's going to be talking on the decisive role of stereotypical beliefs, an exploratory study following 5 persons who developed dementia whilst working. You have the floor.
Thank you. Thank you. Yes, stereotypical beliefs. So I'm not the only author of this study. You see a lot of names there. And for those of you who are interested in more details than those that I can provide in this short little session. So the study is published in an open access journal. So I hope you'll find it if you are interested. So the overarching question that started and led us to create this project was, what happens when when MCI or early stage dementia enters the lives of people who still are working? And this, as we know, is a very still under-researched area and a very tricky question. So we managed to create quite a large research team, and we started this project in 2017, and we call this project Dementia or Mild Cognitive Impairment at Work in Process. And this project has been conducted under the framework of More Years, Better Lives within the GPI program. And this is a really multidisciplinary team. So I come from occupational therapy, and colleagues come from elder and labor law, engineering, psychology, social psychology, and political science. And the goal overall is to develop new knowledge and tools to facilitate continued work and or transition from work for persons with MCI or early stage dementia. That is the overall goal for the whole project. And today I'm going to talk about just one sub-study that is based upon the cases that we have had in Sweden. And within the Swedish project, our aim was to perform an in-depth exploration of the unfolding experiences of 5 persons who developed dementia while still in paid work or employment, and their significant others that could be from work or family or healthcare. And for this very particular sub-study, we wanted to examine how they experience the actions and decisions taken with respect to work, because this is of course something that influences your whole life, but this focus is on work here. And what the consequences meant to the individuals with dementia and to their significant others. a few words about the methodology. We had a qualitative longitudinal design with multiple cases, which means that in this study we did interviews over a longer time, up to 1 year per case, and the number of interviews within each case ranged from 5 to 9, depending on the persons and their situation and what happened during that time. And we used an interpretative analysis called the formal data structure analysis, which also is a little bit more described in the publication, if you are interested in that. So the 5 persons that we managed to find and recruit, and that was not an easy job. They were between 53 and 71 years of age, and I point this out because this project is not particularly only about younger onset dementia, because also we know that we tend to work longer, so that this also is an issue for people who are over 65. So we wanted to have that range in this particular collection. And the significant others that we included, they were of their own choice. So that also varied much between cases depending on their situation and what happened and so forth. So they could be family members, friends, persons from work or from healthcare or rehab, for example. And in total, we had 16 participants, all in all, in this study. So, in the findings, we present 2 main themes with sub-themes, and I want to very briefly point out some of the main issues in each one of these. So, we all know that it's very important with the diagnosis, but what came through very strongly in all our cases in different ways was how significant the diagnosis might be in different ways, and that it also might be a double-edged trigger. So it might trigger positive things, but it could also trigger negative things. And this is related to our very common and sometimes stereotyped image that most of us, or all of us, share. Who can and who cannot get dementia? Because what we saw was that there was a long delay before diagnosis. So dementia was not even considered an option by the medical experts, as the participants were too young or too well functioning when they sought investigation for early symptoms. So they were mainly told, oh, don't worry, don't worry. So it took a very long time for 4 of the 5 to actually get a diagnosis. And one of the cases can illustrate the problem that really might happen, and that is one of the cases. We called her Lisa. She got her early subtle symptoms at work, and she ended up in a negative spiral because they were mistaken. Her problems were mistaken as some kind of, the burnout syndrome. So she had sick leave, and then she came back and she tried to work because she had adapted work tasks, and she failed, and she was completely devastated and more into the feeling of I am just a failure. I cannot do anything. Sick leave, back to work, new failure, sick leave, back to work, eventually being at risk of being totally dropped out of the system with insurances and stuff like that. So her case and also the others show how important and sensitive the first period is. And it also has to do with the idea that we have of what dementia actually is and what it will bring. So even if it was a key event for most of the participants, it could also trigger unwanted consequences. And another case might illustrate that. Maria, who got her diagnosis, and then the employer suggested that she would work for some time, part-time, but then they wanted her to sort of prepare for retirement or sickness benefits, because they expected her to deteriorate rapidly. And she agreed, and she was grateful at that time. But then after having left work, she actually got the message from the medical experts that her situation or her state was very stable, and she would eventually function quite normally for a long time. So she felt that she actually had been pushed out of work far too soon, and she was not very happy with it at all, and her life had changed profoundly. So the second main theme was the issue of making sense and being able to execute one's agency. So it's about really understanding what is happening and how can I have a say. And this is something that we saw really also took time. So for a third of the cases, she had the opportunity, because she was very early diagnosed, so she actually could work for 3 years part-time with a great collaboration with her employer, and then she was involved in choices and options, and she could see that it's best that I step back now, it's time to do it. So actually also 3 of the cases had very good support in a way that their employers really wanted to support them with adapted work tasks. But also this showed how important it is that these adjustments must be made taking the individual situation and sort of profile into account, and it must be based on the right or understanding of the diagnosis, because otherwise it can be quite wrong, or it can have quite devastating consequences. So, to wrap up, some very broad conclusions and implications. The diagnosis of dementia was actually found to be an alien in work life for all these participants. But once it was diagnosed, it could also trigger self-fulfilling expectations based upon the stereotypical understanding that we all share of what it will bring. And having the opportunity to make sense of what's happening, and the opportunity to also feel that I can participate in the decisions that concern me and my situation. That was very important, and it also influenced the participants' journey in this difficult time. And key factors, as we understood the data, key factors for continued work were knowledge and communication between the employers and the employees with dementia, as well as their workmates, significant others, and state agencies. And in this study, we argue that we need a shift from the deficits-focused perspective, where we see people as patients rather than citizens. So we also need to see these people as agents and capable of agency. And such a citizenship approach could facilitate this communication by acknowledging the person with dementia as an agent with the right to self-determination, even if he or she might need support to express wishes and to make decisions. This is also something that is within the rights-based approach. So this is important, and I want to end with this picture where you see one of our meetings back in Toronto. Maybe I said Sweden, Finland, Canada. Well, you saw that. So if you want to contact me, or if you want to check out more other sub-studies and more information, here is the link and my email address. So thank you very much. Thank you.
Thank you. Thank you, Louise. Perfect timing. Do we have time for one question? Yes, I would just wander along with my microphone.
Thank you so much. My name is Hanne Peoples. I'm from Denmark. You were talking about it was difficult to recruit people for this study. Could you elaborate on that? How you went about that and what you did?
It was extremely difficult to recruit people. I've been working with studies on people with like early stages of dementia or MCI for almost 30 years, and this was really extreme, because you cannot really find these people. You don't find them in an Alzheimer association, at least not in Sweden. And we wanted to recruit them as early as possible, but actually only one of them was working when we find them. One of them had left work the week before the first meeting and so forth. So it was really, really, it was a struggle to find them.
Thank you for that question. Thank you, Louise. And
I was just going to say you're looking in the wrong place then, because in the UK they're fighting over each other to get onto research programs like this.
Oh. Yeah.
Okay. Thank you, Louise. With that, we will hand over to our next speaker, if that's okay, and thank you, and absolutely perfect timing. Thank you. Can also hear online. Yes, thank you. Yes. Thank you very much. And our next speaker is Stevie Hendriks from the Netherlands. Stevie is a postdoctoral researcher at the Alzheimer Center Limburg in the Netherlands, and her research area is in epidemiology and diagnostics with younger onset dementia. And you can read it in the brochure, but she's talking about the experiences, values and support needs of former employees. Thank you, Stevie. I will.
Thank you. Well, actually, I'm going to talk about the risk factors of young onset dementia, if you don't mind. Yeah. That is my research, so I will be talking to you about that. When we talk about young onset dementia, we mean the persons who have a symptom onset before the age of 65 years. And a meta-analysis that we have done previously has found that there are at least 3.9 million persons with young onset dementia worldwide. And if you look at the kind of research that has been done on young onset dementia, we see that there is a lot of research on the genetic part, the genetic causes. There were a few genetics that were found, like presenilin 1 and 2, that can cause young onset dementia. But actually, if you look in clinical practice, we only see that 5 to 10% actually have a genetic cause that can be found. So there is a lot of people for which we don't know what has caused young onset dementia. For late onset dementia, there's a lot of research on the risk factors, and there are well-established risk factors for late onset dementia that have also been translated into prevention strategies. And we see that in young onset dementia, this research is still a little bit behind. There are only a handful of studies that looked at risk factors for young onset dementia. One systematic review found 14 articles, but all of these articles only looked at small subsets of factors, so we don't have a really holistic view of what kind of factors are actually associated with young onset dementia. So that was the aim of our study, to look at a broad number of factors and see how they are associated with young onset dementia. And to do that, we used the UK Biobank, which is a very large cohort study within the UK. And this biobank is very suitable for research on young onset dementia. And that's because they have recruited persons in the age range of 40 to 70 years, so in midlife. And that's also, of course, the age range that we're looking at when we think about young onset dementia. So the UK Biobank started in 2006, and they did their baseline assessment between 2006 and 2010. And they've recruited over 500,000 patients, which they are still following up today. And during the baseline assessments, these persons went to different centers and they filled in a lot of questionnaires. They did a lot of interviews. They gave their blood so that the UK Biobank could extract the genetic data. And they gave consent for the UK Biobank to use their medical data both in the hospitals as well as in primary care. So we have a lot of information on these patients. And for this study, we have followed patients up until 2021. And we found that within this follow-up, there were 485 persons who developed young-onset dementia and who were diagnosed within the hospital diagnostics. There were 355,000 persons included in the UK Biobank that were under the age of 65 years. So these are all included in our sample size. We looked at a lot of different factors that potentially could be associated with young-onset dementia. We chose these factors because they were established risk factors for late-onset dementia. So they are they were found within large systematic reviews, and also the Lancet Commission review was used here as well. And the factors that were found in the systematic review on young-onset dementia were also included. So we grouped these factors into different domains, as you can see on the slide, and then the analysis were made first within the domains and then across the domains to get a holistic view of which factors were in the end associated with young-onset dementia. And the analysis that we did was a survival analysis using the Cox proportional hazards, where the time axis was actually the age. So at the moment the people were assessed at baseline, they became at risk, and they were followed up until either end of follow-up, death, reaching the age of 65 years, or getting a diagnosis of young-onset dementia. We did this for persons under the age of 65 years, and in a sensitivity analysis we increased the age to 70 years to account for the diagnostic delay that is often present in young-onset dementia. And we also did a sensitivity analysis to exclude persons who had a diagnosis within 3 years after baseline to account for at least some of the reverse causality. Probably not all of it, because the pathology of dementia can already start decades before the symptoms start. Then if we look at the results first, I want to show you the incidence within the UK Biobank of young-onset dementia. As you can see, the incidence increases with age, and the incidence is a little bit higher in males compared to females. But still, the incidence in the UK Biobank is quite low when we compare it to incidents that were found in other systematic reviews on young-onset dementia. So it might be that we still missed some cases within the UK Biobank. When we look at the main results, here you can see all the factors that were significantly associated with young-onset dementia. There are 15. I will not go into detail about all of them, but I will highlight a few. So we looked at one genetic factor, which was ApoE, and we know that ApoE4, carrying an ApoE4 allele can be a risk factor for late-onset dementia. And what we saw here was that the association for young-onset dementia wasn't quite as high as in late-onset dementia. So carrying one E4 allele was not significantly associated with young-onset dementia, and carrying two E4 alleles was only slightly associated with young-onset dementia. So there is a difference here between young-onset dementia and late-onset dementia. Then, if we look at alcohol use, we can see a bit of a strange result, I think. We looked at alcohol use in two different ways. So the first one was self-report, where we categorized the persons into either abstainers, moderate alcohol users, and heavy alcohol users. And then on the other hand, we had also alcohol intoxication, which was a diagnosis made in the hospital. So these persons were hospitalized based on alcohol intoxication. And whereas we can see that alcohol intoxication is associated as a risk factor for young-onset dementia, it seems that self-reported alcohol use might be a protective factor of young onset dementia. I wouldn't say that is true. We are not sure why this is. I wouldn't advocate alcohol use as a protective factor of young onset dementia. One idea that might have happened here is that we've compared these two groups to the abstainer group, the group that didn't drink at all. And this might be a group that not only includes persons who just don't drink, but also persons who don't drink due to medical conditions. So they may be at higher risk of young onset dementia. We are not sure, so this needs further research, maybe in other cohorts to find out what's going on here. But I would not say that drinking alcohol is a protective factor of young onset dementia. And then last but not least, we see that there are only 2 lifestyle factors actually associated with young onset dementia, alcohol use and social isolation, whereas in late onset dementia, you see a lot of other lifestyle factors that are associated with dementia, like physical activity, diet, and smoking. In young onset dementia, they were not significantly associated, and so there is a discrepancy between young onset dementia and late onset dementia. When we look at the sensitivity analysis, when we increased the age to 70 years, there were a lot more persons who were diagnosed with dementia. All the associations remained significant, and there were some associations that became stronger and some associations that attenuated slightly. And then when we looked at patients who were diagnosed at least 3 years after their baseline assessment, we saw that some of the associations ceased to exist. For ApoE, alcohol intoxication, C-reactive protein, and orthostatic hypertension. We don't know exactly why this is for all of these factors, but for some of them it might mean that they are early symptoms rather than risk factors. For instance, orthostatic hypertension is also an early symptom of Parkinson's disease, and maybe then also an early symptom of young onset dementia, but we need further research to know exactly what is going on here, whether they are early symptoms or not. The take-home message that I have here is that there are modifiable risk factors for young onset dementia, and they overlap with risk factors for late onset dementia. Although there are some differences in these risk factors, mainly in the lifestyle factors and ApoE. And with external validation of our results, risk factors for young onset dementia could be incorporated in current prevention strategies. But as I said, we need some more research on that, and the next steps that we are going to do within our research is to validate these findings in a new Dutch cohort that has been setting up the young onset dementia cohort. So hopefully we can validate the findings that we have now. Then we want to further investigate gene and environmental interactions, because genetic factors are more important in young onset dementia, and it might give a better idea of individualized risk reduction. And then we would like to investigate male and female specific risk factors, which we did not do in this study, but we do think that there might be specific factors like estrogen use or a hysterectomy that could also be associated with young onset dementia. So that's what I wanted to tell you today. I would like to thank the research team, both at the University of Exeter and in Maastricht University. I would like to thank Alzheimer Netherlands for their funding, and I would like to thank you all for listening to my presentation.
Thank you, Stevie, and absolutely perfect timing. So we do have time for one question, and I apologise for getting the topic wrong.
No
so,
problem.
Any questions for Stevie? Any questions at all? I do need to hand you the microphone so they can hear online.
So thank you for this wonderful presentation. You said that some of the risk factors, like the ApoE, was not as profound. Could this be a power issue? Did you look at the effect sizes and also with the factors that did not associate? Was it a power issue that the effect sizes were maybe the same, but you didn't see significance?
Yeah, so it might be indeed that the power was not that high, because there were only 485 persons with young onset dementia. So that could be the case. I don't really know what the exact association is for late onset dementia, so can't really compare that at this moment, but might be the case, yeah. So if we have a cohort that has more persons with young onset dementia, we can look further into these differences, yeah.
Thank you, Stevie, and thank you for your excellent presentation. I'm just going to check if we've got any online questions for you. No, we don't have any right now, but thank you very much for that. So our third presentation this afternoon is from Laura Lebec. And Laura is an early career researcher based at the University of the West of Scotland. She's presenting today on a research project on career guidance and dementia. Thank you, Laura.
Thanks. Good afternoon, everyone, and thank you for inviting me here today. I'm looking forward to telling you about our research project in which we are going to explain to you a little bit more about how we're trying to understand the potential for career guidance to support people in employment with dementia. Our project is titled Guidance for Life.
Do you want to speak into the mic?
Yeah, sorry everyone.
You can have this one if you want.
That's fine now, I'll be here. So yeah, our research is entitled Guidance for Life, Work and Career. Our research is funded by the Alzheimer Society. We're a 3-year funded research project. We're currently just at the 2-year stage, but what I'd like to tell you about today is the first stage of our research, where we carried out interviews with people and explored better the potential for our solutions to creating better outcomes for people who are in employment. So our research is exploring how career guidance can support people who are in employment when they receive a diagnosis of dementia. So we do know that continued employment post-dementia is possible, but we also know that for those who would like to continue work, many do not have that opportunity, and many find themselves receiving a very undignified exit from the workplace. So our co-produced research is focused on exploring the following. If people want to work, how can they carry on in their employment? Do adjustments need to be made? How can we help people with their decision-making? Perhaps leaving work is a good option for people, but often people haven't had a chance to reflect on that. And we also want to be able to try and find out what other opportunities might be available for people and suitable opportunities that might be other paid work or volunteering. So our research journey began about 10 years ago. So back in 2013, we started an interdisciplinary project where we wanted to explore what the situation was for people who were in employment with dementia. Our initial project, funded by the Alzheimer Society, wanted to provide the first evidence that it was possible for people to continue employment post-diagnosis. A further collaboration explored the employment practices of organisations in Scotland, so what the experiences of the employer who is working with someone who has received a diagnosis. So this identified a gap in our understanding of dementia and a need for training and education about dementia in the workplace, as well as a need for practical interventions to support employers and employees affected by dementia. So these projects have led us to where we are today with our 3-year project, the result of developing our interdisciplinary networks. So we learnt a few things over the last 10 years. We learned that every individual workplace experience is unique. People are obviously doing different jobs, working for different organisations, so everyone is facing a different set of challenges. But early support could prevent loss of employment and the right kind of support from the employer. We also understood that help is needed for not just the employees and the employers, but also for health professionals who are supporting people through their diagnosis journey. So we learnt that raising awareness of dementia in the workplace is really important. We also found that knowledge of protection by legislation is quite low. but we concluded that there was a need for person-centred support around employment and decision-making, and that is what has brought us to our research project today. So we wanted to better understand how can career guidance professionals support people who are living with dementia with their employment-related decisions. And in order to start to understand what the potential outcomes were, first of all, we established a project advisory group, and we had group members from a wide range of backgrounds and interests. So in addition to people who are living with dementia, their family carers, a variety of health professionals and allied health professionals, and also career guidance professionals as well. So this was a new discipline to bring into the mix. We then carried out interviews with a really wide range of participants. We wanted to find out, could this work? Can career guidance be something that's really useful to bring into this field of post-diagnosis? So it was a real opportunity for us to explore this question. We wanted to find out what people's perceptions were, not just of dementia, but also of career guidance. What needs to be in place to make this a successful approach? So one of the themes that came out of our interviews in this first phase was that every workplace environment needs to be supportive so that conversations can take place, not just any conversations, but the right kind of conversations. And I've got a few quotes here from people who took part in those interviews. One person living with dementia who experienced her dementia diagnosis while she was in employment said, "I knew everything, but I just couldn't put it all in place. It was like jigsaws being thrown in the air. In the end, I decided nobody's listening, so I just had to resign. I didn't have any other choice." A health professional reflected on a person who she was supporting in employment and said, "Was this lady, she's worked all her life, she doesn't want to stop working. Although employers do seem like they tried, but maybe try in the right way, because do they know the right way to try? No." And then from the career guidance practitioner, we've had to upend our understanding of career guidance a little bit with this, because many people who were asking us, what exactly do we mean by career guidance? So that perception has very much changed, and career guidance practitioners were keen to explain to us they're not just there to give advice, but they're there to do a way more complex process than that. So we also wanted to explore, what does a productive life mean for people? How can we support this? A family carer reflected, who is supporting his partner in employment, you'd be wanting to encourage them to come in, to engage their mind, keep them occupied. I think that would help as much as any medical intervention. A health professional reflected that work is good for you cognitively. And then the career guidance practitioner, when they're starting to unpick what is meant by a productive life, would say, this is how I would approach it. Can you tell me about your dementia diagnosis? What do you understand about the challenges you're facing just now? How can I work with you today? What would you need from me from this discussion? And then we started to think about person-centred approaches. We needed to make sure there was a good understanding of what career guidance can offer today. And I said a lot of us have had to upend our understanding and expectations of what career guidance was. Perhaps we had an experience of career guidance at school, which was just at the point where we were transitioning into the world of adult employment. But career guidance has evolved from what many have understood it to be. It offers a very much a person-centred approach to supporting that guidance for life, work and career. And it's a chance for people to explore what their contribution in life might be, whether that is employment, continuing in employment with adjustments, or exploring other options in society, such as volunteering. Some of the quotes we have here just reiterate that. So the first person was clearly in the difficult decision-making stage, but he said, I needed somebody to grab me by the ears and say, stop talking about when you're going back to work, you're not going to work again. An interesting quote here from a health professional, dementia doesn't mean you've got to end your career. You might have to end that career, but it doesn't mean you'll never work again. And then the career guidance professional thinking about how do you contribute to society? How do you feel valued? Where do you contribute? So our next steps. Our co-production group over the summer has been working on developing these findings using a model of sustainable employability. Next, we're going to be testing what we've developed with expert review, and then it'll be going out to field testing in a real-world setting. But ultimately, our outcome is going to be an innovative approach to supporting people with dementia who have concerns about their employment post-diagnosis. And hopefully in a year's time, we'll be able to share some of those next step findings with you. Just like to share our research team members here. Thank you very much for listening, and very happy to answer any questions.
Thank you, Laura. And again, we have excellent timing, so we have time for a couple of questions. Please, can you use the mic so they can hear online? Thank you.
Hi, Laura. Thanks for that. I'm curious about the use of career guidance. Is that something that's widely available in all employment areas?
Yeah, it's a good question. So in Scotland, where we're based, the career guidance is supported by Skills Development Scotland, and in fact, all adults can access it freely. It's a slightly different situation in England, and we're working with our research team in Northumbria to think about how best we can gather support from career guidance organisations. I don't think it's quite as cohesive as it is in Scotland, but we've had a good start with our Scottish partners supporting that.
Thank you. Any other questions? I'm just going to hand over, and then I'm going to check on the iPad.
Thank you very much for this presentation. It's a pleasure to hear you have come so far in Scotland in this. I have a question about the methodology that career support might use. We had a partner in our project, a Finnish psychologist, who tried a solution-focused coaching methodology to do the work together with the person with dementia at work. Is that something that you have come across?
Yeah, so we're working to develop that approach with our career guidance specialists. So over the summer, they've been going through carrying out interviews with people who've had experience of being in employment with dementia, and they're using some of the tools that they use, person-centered tools. And I think there are definitely elements of coaching in it. We're not wanting to call it coaching per se, as our career guidance colleagues are trying to keep us on track with career guidance processes. But yeah, we'll be looking forward to sharing more what that looks like as we refine that. But yeah.
Okay. Thank you.
Thank you.
Thank you. And any more questions? Okay, thank you. Thank you very much, Laura. Our fourth speaker smartphones, they always go dead when you don't want them to. Our fourth speaker is Bo Smeets. And she's a PhD candidate. Can you hear okay? Okay, thank you. She's a PhD candidate at the Alzheimer Centre Limburg in the Netherlands, and her research project is looking at the work done working with dementia. Compass focuses on continued employment in the context of young onset dementia in the Netherlands. Thank you very much, Bo.
Yeah, thank you very much. I already heard some nice overlap from my colleagues from the UK and Sweden, so that stresses, I think, the importance of continued employment when you have young onset dementia. Let's see, for some background. Yeah, most of the time the symptom onset starts at the workplace with young onset dementia, so people start to experience difficulties when they are at work. However, you are still in an active stage of life when you receive a young onset dementia diagnosis. You have your work, you have a big social life, maybe children living at home, so work is a big part of that as well. After that you receive the diagnosis, there is still a need for a couple of things, like social contact is very important, having routine and structure throughout your week, day, but also have a sense of meaning and independence, and you can all gather that throughout work. However, currently in the Netherlands, there is a lack of guidance and support we estimate that 14 to 17,000 people with young onset dementia are living in the Netherlands. But yeah, guidance is lacking on how to support people who are still working or who want to continue their employment after the diagnosis. But with some adjustments in place, you could still manage some time in your own workplace. So that's what we want to do with the Work Dem Compass project in the Netherlands. We have some objectives, but our main objective is, of course, to support continued employment with young onset dementia and how we support them and can provide guidance for everybody that is involved in this process as well. We have some additional objectives as well, such as improving quality of life, improve self-esteem and identity for people with young onset dementia, maintain an active role in society throughout work, for example, and also very important that we meet the needs of people with young onset dementia, of which work is often one. And at the end, we want to, with this project, we want to develop a compass so that we can provide that guidance and support that is currently lacking. We don't do this alone, of course, so we have several stakeholders involved in this project. You can see them on the screen, and of course in the center, the employee with young onset dementia, but we also involve relatives, occupational physicians, employers, and dementia care professionals. So what did we do in the first phase of this project? We conducted individual interviews. We did that with all the stakeholders involved, and we really wanted to gain insight into their experiences, what are their values, what are their support needs currently in the Netherlands. So that's what we did first, and today we focus on the employee and the relatives. And in order to gain more in-depth insight in those experiences and values, and also look into the future and how can we help, how can we provide support, how do we need to do this, we also conducted focus group discussions with all the same stakeholders again, and again today focusing on the employees and the close relatives. So our results from these two groups. This is the figure that we, that shows our results from the employees and the relatives. So it all starts with the main team in the center, that's desire to work. So it all starts with desire to work, and all the other components that are around desire to work are conditional and interconnected to this team. So they are very important to meet the desire to work. So I will go to them briefly. So the first one, desire to work, it's the main team. People often, stress that they still wanted to work, but it was often not possible, or as we saw before, people didn't even have the chance to stay at work because long time a diagnosis was not clear or something like that. But they really, most of the people really had the desire to still, continue their employment at their own workplace. So what is very important in this, it's the importance of a diagnosis. We already heard that often there is a big delay. People think they have a burnout or depression symptoms, and it often takes a long time before people know what is going on, and sometimes it's too late to even provide support or help those people to stay in their work. So the diagnosis is very important, and it's also very important that you communicate it, because if people know, they can support you. So the second one is knowledge, awareness, and understanding. We found that often there is a lack of these three, and not only within professionals, but also employers. People just don't know about young onset dementia. As we said before, people think it's a burnout, depression, or something like that. So it's misunderstood, and therefore really important that it is in place, because otherwise you cannot support somebody. The third one is about communication, decision-making, and collaboration. So I already mentioned shortly that communication is very important, not only at the beginning when you have the diagnosis, but also during the whole process at work, that you want to stay at work or something, decisions that have to be made. People want to be involved in that. They want to seek with each other how they can continue their employment and make those decisions together. And also it is very important that there is a collaboration between all relevant professionals. So not only the employee and the employer, but all relevant professionals involved as well. So that was also an important theme that was mentioned by the participants. Then a more practical point, work adjustments, involvement and support. Work adjustments are often possible, but you need to discuss that with each other and see what can we adjust. Some workplaces can be adjusted better than others, so you really need to look into that together, and that's where the involvement comes along. Involve relevant professionals, involve the employer, and together you can make sure that the right adjustments are made and that you are supported at your own workplace and can continue your work. So that was also stressed as an important point. But as we heard before today, it's not only about staying at work. Sometimes people want to quit work or want to do something else without being at their own workplace. So it was also important for them to look at phasing out work. When do I make the decision to stop, or when is it time for me to leave and do other things? So that was also an important thing, and also what can I do in the future? People have a lot of abilities, possibilities that they still can do, but really want to think about it already when they are still in their employment. So that was also an important point that was mentioned by all of our participants. So then what's next? We already did the interviews and the focus groups, and now we are currently here. And we are now creating some, we are trying to set up some sessions in order to develop the Work Dem Compass. So that's what we are currently busy with, and we take all the things from the interviews, the focus groups. We're also conducting a scoping review on how can we provide that support and that guidance. So how can we do that, and how can we develop something that is the compass? So that's where we're currently at. Then some take-home messages. It's fundamental to increase awareness and knowledge about young-onset dementia, not only within professionals, but also at the workplace. People often do not recognize it, but if we can increase this, diagnosis maybe come earlier. People are getting better support at work and can continue their employment for a longer time. So it's important. Then the importance of collaboration among stakeholders. There are a lot of people involved, as you saw, so it's really essential that they collaborate on the same level and that they are all on the same page, because that only facilitates the continued employment. There is no one-size-fits-all solution for continued employment. Some employees want to stay at work, some don't want to stay at work. Everybody has other capabilities, wishes, needs, desires, so it's no one-size-fits-all solution, but if you communicate openly and you discuss it, then there might be a solution for everyone in a different way. And I think context-specific research is needed, such as I did and my colleagues who are presented before me also did. But I think learning from each other is essential, because there is a lot of overlap, I guess, in the research that we do. Then I want to thank all my project partners that are involved in this project. And if you want some more information or there are any questions left, then thank you for listening.
Thank you very much, Bo. Another very interesting talk, and also perfect on the timing. We do have time for a couple of questions before our final speaker. Please, can you speak into the mic for our colleagues online? Thank you.
Thank you. Great presentation. I'm interested in the employers that were in the focus group, because obviously it's very easy to be in this room and be like, we're very on side with, like, we can see the benefits, but how do you ensure, or did you get a sense from them of how you ensure their collaboration and selling to them almost that workplaces are richer for making these adjustments?
Yeah, I guess the main thing is that they're just not aware of it. Yeah, right now. So it's first essential to increase that awareness, and I guess the employers that we talk to are really willing to keep somebody in their company because often they have worked there for a long time. So I guess they are willing to, but they just don't need how. They don't know how they need to do it. So that's that's a challenge, but we hope that we can make that possible.
Nice one, thank you.
Thank you. Do we have any more questions? Any more questions? Okay, I'm just going to check online to see if we have any questions from our colleagues online. No, with that, I'm just going to thank you, Bo, and hand over to your final colleague from the Netherlands.
Yes.
So our final speaker in this session is Sophie van Westendorp, and she is also a PhD candidate from Radboud University Medical Center in the Netherlands. And Sophie will be speaking to us about the Dutch landscape of dedicated post-diagnostic care in young-onset dementia. Thank you, Sophie.
Yes. Thank you for this introduction, and thank you all for being here. And thanks to Alzheimer Europe for the opportunity to present my work here, which is part of the YOD Included project. YOD Included is a large national consortium performing research in the field of young-onset dementia. And I invite you all to talk to my colleagues as well about their work. And these faces are identical to the faces of my colleagues. So if you look for those, you'll be fine. But I want to talk with you about the Dutch landscape of dedicated care, post-diagnostic care in young-onset dementia. And I want to start by providing some numbers. When we look at the world, there are 45 million persons living with late-onset dementia compared to 3.9 million persons living with young-onset dementia. And this latter corresponds with 0.05% of the total population. When we look at the numbers in the Netherlands, you will see that there are 275,000 persons with late-onset dementia compared to up to 17,000 persons with young-onset dementia. And what I want, and I assume this is something everybody here wants as well, is for all of these 3.9 million persons and their supporters to get the care that fits their needs. So they will get dedicated care, by which I mean care that is appropriate for their age and adjusted to their specific needs. And they will get this care when they need it and where they need it. So if they live at home, in a nursing home, here in Helsinki, or in my hometown. But why do we want this? Well, it's not only because dedicated care sounds really dedicated, committed, and strong. Previous studies have shown advantages of dedicated care. So persons with young-onset dementia and their supporters who get dedicated care have more continuity in care, they are more satisfied about the care they get, and they experience a higher quality of life. So then the next question is, if it is this great, why doesn't everybody have it? Well, there are challenges at providing dedicated care because the prevalence is low, namely the 0.05%, and everyone has their specific needs. It is likely that organizations nearby do not provide the care that is needed. In that case, the person and their supporters do not get the care they need, or they should know where to seek this kind of care elsewhere. And this approach is undesirable as it leads to unpredictable and variable care or a high chance of not getting the care that is needed. Instead, you would want to put the needs of the person and the supporters at the center and have a coordinated collaboration of care and support to fulfill these needs. And this is something we call integrated care. In the Netherlands, we have two national organizations who help organize integrated care. One is the Young-Onset Dementia Knowledge Center, The other is Dementia Network Netherlands. And these national organizations are similar in the basic of their mission, namely to improve the quality of life for the person with dementia and their supporter. But there are also differences. So the Young-onset Dementia Knowledge Center focuses on care and support for young-onset dementia and is one network of 39 healthcare organizations and 6 knowledge partners, while Dementia Network Netherlands focuses on care and support for dementia and is 60 to 65 regional networks. When we look at how the members of these national organizations are distributed across the Netherlands, you will see that there is overlap in areas. And we also know that these members do collaborate with each other. The blue triangles are regional networks of Dementia Network Netherlands, who also contain an organization that is affiliated with the Knowledge Center. But what we do not know is if these collaborations are also used for care and support for young-onset dementia, and if they are, how does these collaboration exactly look like? And that left us to our question, how is the Dutch landscape of dedicated post-diagnostic care and support in young-onset dementia organized? And to answer that question, we developed a self-scan young-onset dementia. The contents was based on our research proposal, desk research, a previous self-scan, inputs of the organizations affiliated with the Knowledge Center and the Knowledge Center itself. And we divided the questions into 3 parts. One part about the type and amount of dedicated care that organizations provided. The second part about the way they organized dedicated care and support. And the third part, how they collaborated on different levels. So how they provided integrated care on a local level, a regional level, or a super-regional level. We tested this version with 2 organizations on wording, phrasing, and feasibility, and then distributed the final version to the 39 organizations affiliated with the Knowledge Center, with the instruction to fill the questions in with the relevant members of their team. And I'm able to show you some preliminary results of 18 organizations who have filled in the self-scan. And I want to present to you how they provide integrated care on a regional level and what they experience as facilitators and barriers in these collaborations. So looking at the 18 organizations who filled in the self-scan, 8 organizations were part of a regional network for young-onset dementia versus 10 who were not. And of these 8, 7 used a regional network of Dementia Network Netherlands for this cause. So those are one of the blue triangles. And one organization was part of another regional network. And if we look at some details of these 8 regional networks, the smallest contained 3 organizations, while the largest was consisted of 24 organizations. Most networks were coordinated by appointing one leading organization, and all regional networks had a person appointed for the coordination of the networks. And the hours of the person available for these activities differed from 0 hours per week till 24 hours per week. And this is quite a difference, and it also relates to one of the most experienced barrier, namely the limited amount of time, resulting in prioritizing other types of care above the care for young-onset dementia. Followed by unclarity in vision and agreements on how care and support should be organized. But also other experience barriers were difficulties at implementing care standards in practice, not having a clear leader within the network, and difficulties at putting the needs of the person and the supporters at the center, and having different cash flows. When we look at the facilitators, you will see that some of the opposite facilitators in some networks are also mentioned as some of the opposite barriers in some networks are also experienced as facilitator in other networks. But one of the most experienced facilitator was that there was a well-standing and coordinated collaborations with the participants in which they knew each other well and have an accessible communication and contacts. And this, the other most frequent mentioned facilitator was knowing where some kind of expertise was within a regional network and how to use this expertise in practice. And then the other facilitators were putting the needs of the person and the supporter and the person and the supporters themselves at the center, having clear agreements on how care and support should be organized, having a clear leader within the networks, and the ability to address bottlenecks when they pop up. So to come to some preliminary conclusions, these preliminary results gave us some insights in how the landscape is organized. And I think what's notable within these results is that the opposite of barriers in some networks are experienced as facilitators in other networks. And for me, that only stresses the urgency to collaborate with each other and learn from each other how we can turn a barrier into a facilitator. But more results have yet to come to gain full insights, and this will provide us an overview of the available but also misdedicated services, insight in how dedicated care and support is provided and how it can be provided, and all the experienced barriers and facilitators in these collaborations. And that will also be part of our next project, that we will guide a maximum of 3 regional networks to overcome these barriers using participatory action research. I want to thank you all for your attention, and I also want to thank the whole team and our partners, as for them this study would not have been possible. And if you have any additional thoughts or questions, feel free to contact me. I left some business card next to the door, so you can take them and contact me at any time. Thank you.
Thank you very much, Sophie. And again, another very interesting project. And I wish you well with it.
Thank you.
I think I might be advising on it as well. So I was very interested. So, do we have any questions for Sophie? I'm just checking online. We don't have any questions online right now, but are there any out in the audience? I have one, Sophie.
Okay.
For a lot of organisations, how you perceive a barrier and a facilitator can also be perhaps connected around communication. Is there something that was coming out of the facilitators in the preliminary findings that was about clear communication, perhaps? What mechanisms did they use?
Yes, so we also added a question about the way they communicated within regional networks.
Yeah.
So we asked organization which platforms they used, and most mentioned platforms were actually using emails through Teams, or just contact each other with special apps like Silo.
Did they come together with face-to-face communication?
They sometimes did, but not all of them in these preliminary results. What did I want to say? Yeah, so these preliminary results, sometimes they did, sometimes they used other communications mechanisms. Yeah, but I think the most experienced facilitator was that they knew that the participants in the regional networks knew each other well and knew where to find each other. Yeah. So other questions we asked was how they experienced, how they were, how they could find each other within the networks, they could find each other in most networks well, but it differed.
Yeah, brilliant, thank you. I have this theory that it's often easier when you're in the same room together to have the communication, so it would be interesting to see your findings.
We will look at that further in the next project. We could ask them. Yeah. Thank you.
If we have no further questions, I'm conscious that perhaps we're coming to the end of this period and people are wanting to catch the buses. So it's really lovely for you all to come and present. I found it really interesting and I want to thank each and every one of you and thank you all for attending. Can we show our speakers your appreciation? And thank you very much.